breast cancer, and this is as something that affects very many women, and as of yet we are not able to eradicate it completely from our society, or rather bring enough awareness. And that's the conversation that we're going to have today. And we have a well orchestrated panel that's going to take a look at the medical side of things, experience, and of course we'll also be taking a look at a survivor who has been through it, recognizing that she has it, dealing with the emotional and physical effects of the disease, and emerging victorious after treatment. Now, this is a very important conversation, this being Breast Cancer Awareness Month. So this is very important, a conversation that we should have. And obviously, there is the issue of prevalence. So we will be having a very important conversation on that. So we start off, I'll introduce our guests. We have, to my immediate left, we have Joe Kiboy, who was a caregiver and has witnessed firsthand what the disease can do, the treatment, and what the needs of someone suffering from the disease are. And then we have our very own Alice Kadimane, who has lived through it and emerged victorious. So you are a survivor and a warrior, and your sentiments will be very important to the conversation. And last but not least, we have Dr. DR.MWANZI of Aga Khan Hospital. You will be giving us the medical side of things, and of course that knowledge is very, very valuable, and of course that is somewhere I would love to start. So Dr. DR, would you define for us, let's not assume everyone knows what breast cancer is. What is breast cancer, and who is at risk of getting this disease?
Okay, thank you for inviting me. So breast cancer is cancer of the breast, and essentially cancer is a disease where you have abnormal cells that grow rapidly and avoid the normal mechanisms for dealing with abnormal cells.
Yes.
So in the breast, they form a lump, and it can be in any breast, the left or the right, and it can affect both men and women.
Yes.
So even men have some breast tissue, so it's not only a disease of women. So it's called breast cancer because it starts in the breast, and there are several stages. When it's in the early stages, it's in the breast. It can go to the lymph nodes in the armpit, and when it's in the advanced stages, it has spread to the other organs such as the lung, the liver, the brain. It can spread to any organ. So the commonest risk factor is actually being a woman. So because women have estrogen, and the breast cancer is like fed by estrogen. So women have a higher risk of getting breast cancer than men. And then older women have a higher risk. The older we grow, the more we have abnormal cells in the body.
By older, you're talking over 40, or what would...
So if you look at globally, they say the risk is higher for those over 50. But if you look locally, we have a significant percentage of our patients who are under the age of 45. So there are geographical differences in terms of age, but cancer in general, the older you grow, the higher the chances of having cancer.
The more vulnerable you are.
Yes, the more vulnerable you have, because you've lived longer, you've had more exposure to chemicals, toxins, carcinogens, like you said. So obviously the risk is higher when you're much older. Having said that, there are cancers that are more common in children
than in
adults.
Older people.
But so other risk factors for breast cancer that are related to women is having your first baby over the age of 30, not breastfeeding your children, and then
really,
yes,
it's not a myth.
Yeah, so it's not a myth. So breastfeeding is actually protective, especially if you breastfeed for more than 2 years. And then other things that women cannot control is the age at which your period started. So if you have your period starting earlier, it's been shown that the risk is higher.
Oh, really?
And if you achieve menopause at an older age, then the risk is higher. And that's basically because the length of time that you've been exposed to estrogen is longer. Yeah, so those are some of the factors. Then obviously other things like obesity is a potential risk factor. And smoking, not so much related, but obviously smoking is not a good thing. So most of the risk factors are related to women in terms of how long they've been exposed to estrogen.
All right. Yeah. Now, so I would like to know about the how you detect breast cancer in your body. And before you give us that, I would like to bring Alice in to give us her experience. You were diagnosed, and how did you go about, or how did you come about knowing that you had this ailment?
The first time I got a lump on my breast.
Yes.
Initially, every other year, I would go for normal checkups.
Yes.
So that particular year, I went and I got a lump.
Okay.
So I was advised by the doctor to go for a biopsy, and which I went, but the results were not very clear. It was a FNA.
Okay.
Fine needle aspiration.
Yeah. Okay.
So the fluid that was removed from the lump wasn't so clear. So I went for a minor operation. Then after a week, when I went back for the results, it was positive.
Oh, so the minor operation was to remove the lump and then have it then tested.
Yeah.
All right. So, and you have also had experience. You cared for somebody who went through this disease. Could you tell us how the diagnosis was done, how the discovery and diagnosis was done?
Okay. First, thank you for having me here. One of the biggest challenges, by the way, that we face as Kenyans is that process of diagnosing cancers.
Yes.
In fact, I won't hesitate to say that probably about 75% of caregivers are actually palliative caregivers. And I'm sorry to say that, but I say that because most of our patients are diagnosed very late.
At late stages.
Now, that has a lot of challenges, especially in the diagnostic process, because a lot of money goes through this.
Yeah.
And you actually wonder how come doctors can't diagnose. You know,
Early enough.
there should be a system where if a patient has a suffering of some kind, you know, there should be warning bells where it should be one that now doctors should move in and see what is this,
Yes.
is it possible cancer?
And prioritize that
Especially
patient.
today that more and more cases are becoming cancerous.
Yes.
We don't know what, you know, unfortunately cancer is very difficult to detect in the initial stages.
All right.
But,
so I'll stop you there as your mic has a problem. So as we fix that, I'd like to pivot back to Alice just to tell us now, after the diagnosis, what went through your mind in terms of experience? Because a lot of the sentiments that are out there or the attitudes is that breast cancer is, or any cancer of the sort, is a damning diagnosis. So in terms of your experience mentally, how did you go about it, and how was even the news broken down to you?
The truth is, when I went back for the results, I wasn't given the news very well.
Okay.
It wasn't done so well. I went, was given my results, then the doctor just told me, you have cancer.
Wow.
So I looked at him, and before I even asked anything, he had already recommended for an operation,
Right.
which I had not actually really
Prepared for?
Mentally.
Yes.
So I looked at him, and then he started giving me stories that there was a woman who came there, and he advised the lady to go for an operation, and she refused, and she died.
Wow. So this is the information that's supposed to push you into...
to go, I don't know, to go straight away for an operation just immediately after you've been given the results.
So you are still dealing with the shock of the diagnosis, and here you're receiving this sort of horror stories about people who refuse to comply. So how did you go about it and coming to terms with it before the operation? Or did you just follow, you know, his...
It was actually at Mata, and after that incident, I went to the field. I cried for about 3 hours.
Wow.
And then from there, I decided to call my eldest brother, who has interacted with guys who work in hospital for a long time. So I told him, this is the results from the operation had been given. Then he told me, no, you relax. maybe the doctor is not right.
Right.
So he advised me to seek a second opinion from another doctor, which I did. But then I didn't know so many doctors, but I had a gynecologist at Kenyatta National Hospital. I decided to go to the gynecologist. So I waited for my turn to get into the doctor's room, went, gave him my results. He looked at it and he just laughed. And I got encouraged because of that. So he told me, no, this is not something very serious. It hasn't gone very far. He decided to call me 2 more other doctors.
All right.
An oncologist and a surgeon. So we met, we had like a small meeting with the team, and they decided to put me on treatment.
Okay.
Which was chemotherapy.
Chemo, yeah, which I would get to. But let's talk about the issue of diagnosis and some of those loopholes, because today in the nation we have a story about a woman who has gone through 2 years of agony because the diagnosis process seems to have had loopholes, because all the husband says is that he received a fist-sized matter from her right side, her right breast, as part of the process that they were undergoing, and they say that it's an intern who conducted that procedure, and they're blaming it, and he was before the National Assembly Committee on Health, and they're blaming it on the hospital because apparently all that wouldn't have happened if all the things were done right. So when you hear her story, Dr. Sitna, what do you feel? Because she definitely encountered, difficulty psychologically, and also in terms of the information she needed on how to handle said disease.
Yeah, I'm really saddened by hearing that, because getting a diagnosis of cancer is not an easy thing, and it usually requires time to process the news, because I think it's also because of the way we view cancer. Every time someone hears about cancer, they immediately think, I'm going to die. Yet, as Alice is here, it's proof that that's not true. And so, as health workers, we really need to up our game in how we deliver this news and how we walk the patients through that journey. And it's not a one-day journey, it's a journey over many years. And just to go a bit about the diagnosis. So one of the other challenges we face is that people think that it's easy to make a diagnosis of cancer and to initiate treatment. It's not like saying, I think you have malaria, you go and get a prick, we look under the microscope, we say, yes, you have malaria, and we start you on treatment. In 5 days' time, you're feeling better. So that's not the case. So many times, some patients will present with clear features that this is cancer, and some patients will have multiple things that need a lot of tests before you find a diagnosis of cancer.
And
so,
if it's very clear, does it mean that it's more advanced?
For example, the breast is like an outward organ.
Yes.
So it really depends on where the cancer starts. So for the breast, a woman might say, I noticed a lump, or I noticed that my nipple has gone in, or there are skin changes, or I have a swelling in the armpit. So that's the first clue. And the first thing to do is to do a mammogram to evaluate and see on an X-ray what that is, because not all breast lumps are cancerous. We have quite a number of breast lumps that are not cancerous.
Right.
Then after that, we would do a biopsy, which is to take a small sample from the lump and take it to the lab. So you see, that's a second process. So you come, you are seen by the doctor, then you go for an X-ray, a mammogram, and then you go for a biopsy, which is ultrasound guided. So those are 3 steps already, and we haven't really told you what it is. And then the sample is taken to the lab, and they tell us this is cancer or not cancer. And even if it's breast cancer, there are very many types of breast cancer, so they do further analysis on the specimen. And then after that, we say, what is the stage of the disease? So it means that many patients will undergo CT scan of the chest and the abdomen to determine whether this cancer is just localized to the breast or it has spread to other organs. So you can see that's a process that can easily take you up to 2 weeks to actually come and say, yes, you have breast cancer, this is the type of breast cancer you have, and this is the stage, and so this is the treatment plan. And I like what Ali said, that when she went to see the gynecologist, he called in the oncologist and called in the surgeon, and that's what we call multidisciplinary care, for you to understand that breast cancer cannot be managed by one person. It requires a team. And so having that discussion upfront before you start treatment is very important. Having said that, that's not possible in all centers, yeah? So there are some centers that just have surgical care, and then some centers will have oncology care in terms of chemotherapy, and then only in Nairobi is when you'll get things like radiotherapy, which is also a key component of treatment. So it's not all centers that can give you everything in one place.
Yeah, absolutely. That sort of multi-pronged attention.
Yeah.
Now, Mr. Kiboy, I cut you short. You're telling us about the diagnosis that you were privy to, what you saw with your loved one, and as well as what was I'll allow you to finish and also tell us what was the sort of situation after, in terms of delivery of news and ushering into how you were ushered into the course of treatment that was necessary at that particular stage.
Okay, in my case, it was quite a journey because my wife had what they call it's a type of non-Hodgkin's. It's Burkitt's lymphoma. It's a lymphatic cancer. And it's one of the fastest growing cancers, right? Also, one of the easily treatable cancers. Now, in her case, there was a lot of urgency that this was to be captured early.
Yes.
But it took over a month. Now, the thing is that, you see, the early symptoms for cancer in many cases are very varied. Like in this case, she had, they said it was gastritis. She was having heartburns, gases in the belly. And the doctors went through that process. They would start from the small process, thinking it's a small, indigestion.
Yeah.
They give her medicine for indigestion. It doesn't go. Then they go progress again. It's like, in this case, it was like a guessing game.
Yeah.
Right. Then, and it gets worse. Okay, because at one time she's not able to go and to the bathroom. Then she's in a lot of pain, and all this. This is already a cancer that is very fast growing. It's in the body. Over a month, she has not been diagnosed.
Right.
And we are going round from one test to the other, colostomies, MRIs, and all these are very, very expensive procedures. Now, and then you in between, you get lost as a layman. You don't understand. And 100% of us in our homes, we do not expect cancer.
Yeah.
Cancer 10 years ago was totally unknown in our communities. Today, it is there.
Yeah.
And the time my wife was getting cancer, it was still that process that nobody, like me, I never expected cancer to get into my home because we were never taught. There's no awareness in this country about cancer, nothing. So when it knocked my door, it was a shocker. And when the doctor came, in fact, we had a small tussle at the hospital because I had to get a radiologist from outside. The hospital did not want me to do that. Now, and if you look at this, it's all about money. They're not thinking about the patient. They're saying, no, we will do it ourselves.
Okay.
But I am saying my patient needs treatment. So
worse.
These tussles come in, and they really affect both the patient and the caregiver at the time. But that process, at that situation, you're not a caregiver.
Yeah.
You just expect it's another disease, they're going to come out of it and everything is going to, be okay. So now, when they came to decide to do a biopsy, that was another issue. You're told to pay a certain amount of money because the biopsy tests have to be taken to South Africa. You can't understand this country today, this time we can't do a biopsy.
Yeah.
Only to come and realize the biopsy was actually being done locally. But because they want money. And I'm sorry I'm going to have to talk to this because we really need to change our mentality about the way we treat each other, because we are human beings and we need some sympathies for each other. So now that process, when you're being told your biopsy is being taken to South Africa, and here you have a patient, though unknown at the moment, that he has a very fast growing, type of cancer, it doesn't make sense. Now, I will tell you for sure, I spent so much money, through friends and everybody else, so much money on the diagnostic process. I've not even come to the cancer. Then when now we are coming to discover, and by the way, I discovered cancer because the person, the radiologist who I brought in, came and told me, look, I am going to do you a favor. I'm going to give this biopsy to the hospital because it belongs to the hospital. But I'm going to take a little bit of myself, which was an illegal thing at the time. I'm going to take a little bit of it and go and give you a diagnosis as fast as I can.
Right.
I was waiting for the hospital to give me one, which was going to take 2 weeks. This guy
South
gave me a diagnosis the following day and told me, I think your wife has cancer. And this cancer is in the non-Hodgkin's lymphoma group. But I am not certain what specific type of cancer. I need a bigger biopsy. I need the rest of the biopsy to be able to give you a conclusive answer. That was another issue.
Yeah.
Getting now the biopsy, which is my property, it's my wife's biopsy, was another hassle. I was being taken from one place to the other, you know, just being run around, and you can't understand why. You go to some places, they're telling, no, you have to pay so much because we have to get it to you. And, you know, others are telling me it went to South Africa.
Wow.
You get mad, you get annoyed with the system, you want to fight people, you are screaming in the hospital corridors, you don't know what to do. Now, you wonder, what is this all about? Why do you have to take somebody through such processes?
Yes.
But anyway, to cut a long story short, we got the final results, and it was confirmed it's non-Hodgkin's lymphoma. By that time, my wife had an extended stomach, she had been jaundiced. In fact, I say God is great because a cousin of mine came and told me, look, even before we had even gotten the final results, to me, you know, I think you need to take your wife to India. Forget about this. If you can, take your wife to India immediately.
Sort this out.
It's very unfortunate that in such a modern country, you're being advised to take your patient out of the country to do that.
Yeah.
But that's the story for another day. But the process of the diagnosis needs to be improved, and we can do that. We have the knowledge, we have the know-how.
Yeah, I mean, cancer itself is a huge disease, and the common denominator here is that the diagnosis process is quite a headache. We have money coming in, we have disagreeing medics. Dr. Sitna, how can this be solved just to make sure that, you know, the patients are not suffering even more than they need to, because while we're tussling and arguing and trying to figure this out, we're having patients that are degenerating, like in his case.
Yeah. So I think it's a multi-level process.
Yes.
We need to improve standards of healthcare in all levels. So at the primary healthcare level, we are talking about early detection, screening, and prevention, and moving to other levels of hospital. So at a level 4 hospital, it should be easy for someone to at least get diagnosis, because we expect that at a level 4 hospital, we have a functional radiology, a functional lab, and surgeons, and maybe a visiting oncologist coming on board. But if you look across the country, this is something that's not there. Then if you move to level 5 and level 6, which is the tertiary health level, that's a more comprehensive cancer system where you have everything in under one roof. So there's definitely a need for improvement of all these facilities, so that happens to be a national government or a county government responsibility, because not everyone is able to come to a private hospital to access care. And then the other thing that we need, we already have a policy in terms of cancer, but the implementation and dissemination of this knowledge is not there. And then if you also look at the public awareness of disease, so when we started with the HIV epidemic, there was a lot of, if you look all over the country, you're going to see billboards, you're going to see messaging everywhere across the country, it's there. But if you look at cancer, there is no messaging, there is no awareness. So you might have awareness in urban centers, but not as much awareness in terms of public awareness and in terms of healthcare awareness, in terms of what do I do, what are the signs and symptoms, possible signs and symptoms of cancer, what should I do, and how do, I mean, all those things will lead to maybe people coming earlier, and if we up our health standards in the level 4 hospitals, that might make the diagnostic process easier. Having said that, the process is expensive because the tests are expensive.
Yeah.
These are not simple tests that are just done in any lab. For example, a diagnosis of Burkitt's lymphoma, even in this day and age, can be a difficult diagnosis to make because it mimics other conditions. And also, if you look at non-Hodgkin's lymphoma, there are over 70 different types. So you have to get the type correctly to give appropriate treatment. So there's definitely need to be improvement in multiple levels. It's not a simple one thing that will change the process.
Yeah, and in his case, the non-Hodgkin's lymphoma that his wife was diagnosed with did mimic other symptoms, and therefore might have contributed to that difficulty.
Delay.
But it was unnecessary with all the stories of South Africa, and that is, even psychologically, it's not necessary at all.
So I would say that it's, if you're not satisfied with care in one facility, there is always an option of getting a second opinion. I think people shouldn't feel stuck that I just need to continue with this one place, that they can actually go to another facility to get the second opinion that they need.
But it's a question of more money, I would imagine.
Yes, but I think if we had a better structured like health insurance fund, so the NHIF has really come in and taken a bit of the load in terms of paying for scans, paying for biopsies, paying for treatments. But I think that we need to push that a lot further so that the person bearing the cost is not the individual person, but we are all contributing to this insurance fund, and we should actually get healthcare, and that's in line with what we're talking about, universal healthcare, that it's care that should be accessible and affordable and should not lead to financial decline of communities and families.
Because we do have a consistent a panelist here who always says most Kenyans are just one cancer diagnosis away from poverty.
Right.
Because it actually drains everyone off of their financial power. Now, I would like to get into breast cancer has sort of more clearer symptoms, right? So you said yours was diagnosed as a lump, is that correct? And was this maybe an easier way, according to the doctors, was this something that was it just detected by mammogram, or was it the sort of test that they do by touching and finding out? How was it found?
Actually, like that was about 15 years ago.
Yes.
And the only thing I knew was anytime you have a lump on your breast, it has to be removed. But the initial test that I underwent was the FNA, which for me it's not very necessary. It is a very, very painful procedure, and I did it. The pain I underwent, I would never want anyone else to do that FNA.
Right.
If you have a lump, they would rather just remove it, take it to the lab, and do the test. I did that. Then after 2 weeks again, I went back for the results. Then I was. This is when I was told to go for a minor operation to remove the lump. Again, I went back to hospital. I did the operation. Then it was taken to the laboratory. Again, I waited for 2 weeks. Again, that's about a month.
Yes.
Yeah. So I don't think
if it was a fast progressing one, then it could have been.
If it was just you go to hospital, you can feel the lump, or you can feel the size of the lump. Why can they just take you to the laboratory for an operation so that it's just removed and get tested? But you go through all those stages, which I didn't understand about the FNA thing.
Yeah, and I guess understanding is a pretty big issue. In her case, it was a lump that was found. What are the other symptoms of breast cancer that people need to be on the lookout? Because it does present in different ways that you can actually see. And the positive thing with breast cancer is that you can self-examine and find that something is not right.
Yeah, so the commonest presentation is actually a lump, and then the other thing that people have is a change of the skin over the lump, so it looks like an orange peel, and then the nipple, which is usually like an outward projection, can go in.
All right.
Some people actually don't even have a lump, but they have like it's red, and it's warm, so it's often confused as an infection, yet it could be cancer, but doesn't have a definite lump. Some people actually just present with a lump in the armpit. We have a certain number of patients who already have a disease that has spread to other organs, so they may not have noticed their breast lump, but they might come with back pain or difficulty in breathing or abdominal pain because the cancer has already spread to other organs. So in those cases, then you're working backwards to find out where is the where the cancer started.
All right.
And usually the lump is painless initially until if it has grown significantly, then it can become painful. And we have, unfortunately, patients who come when that has already made like a wound, like a fungating wound, which is smelly and bleeding. So we have all that category. More importantly, we would like to catch the cancer before you even notice a lump. And that's why we advocate for early screening with a mammogram, because the mammogram has the ability to detect the disease even before the patient or the doctor can feel a lump. And if you find it on mammography for screening, then the chances of cure is very, very high.
And speaking of screening, every now and then we hear about free screening. So if it's free, please take advantage, because early diagnosis is quite important. I'd like to mention that the Standard Group, together with Jubilee Insurance, are holding a free cancer screening for its employees. So this is something that you can actually take advantage of if you work for the Standard Media Group. But often you find hospitals and organizations holding camps, having tents pitched up all over town or in your local hospital, and they're promising you free screening. So do not be afraid, because there is stigma surrounding cancer that makes people averse to they don't even want to know in the first place. And did you experience said stigma with your wife or the people around you as you're trying to get her treated?
Ideally, in my case, there was no issue of stigma, because the type of cancer she had did not create such a situation that, you know, she'd be stigmatized, because most of the stigmatization comes because of the type of cancer. One, if it becomes an open wound, it becomes repellent to people. Two, men, if they find a wife is going to lose one breast, I don't know why men can't live with a woman without a breast. That beats me. They shun away. Then there's, of course, cervical cancer, which brings in a lot of complications. It's really horrible for women. So those are the types of cancers that actually bring in stigmatization. But having said that, the kind of situation caregivers go through is ideally financial. And if there's a word like we could use, financial stigmatization, then maybe we can bring it into play, because the thing is that, you know, when you get sick on a normal sickness, people will come to your fundraising because they know this person is going to go for a one-time operation and is out and it's over. Cancer is a continuous thing. You need money for the chemotherapy. And one thing I'll mention that most people don't know is that it's not only chemotherapy that is expensive in cancer management. I realized that, and this is something nobody had told me, that there are two stages to it. The first one is to manage to give the chemotherapy. Now, once you're given the chemotherapy, then there's a second stage, which needs now to manage the probable opportunistic infections that come because of the immunity, depletion of the body.
It makes you weak.
Now, I realized when I was in India, the chemotherapy was costing me $3,500 per session. And if Lydia got the infections, which will definitely come because she's getting in contact with people and other things, it also cost about $3,500.
Wow.
Now, in India, they manage that very well. Is that you're given, when you come out of chemotherapy, you're given specific instructions and you're given to-do note that should this happen, especially if the temperature reaches a certain, you need to take the patient to hospital immediately. It's an emergency because they get the temperatures can kill you, and the infection can spread.
Yes.
And I did know it can spread to a situation where the body actually there's a situation, and the doctor will ascertain this sepsis neutropenia, which is what killed my wife.
Wow.
That is the body now becoming completely infected, that you cannot go beyond, you cannot go back.
Yeah.
That is certain death. Now she got to that stage. And it's because of the way we were managing that small bit of infection. And I would be bold enough to say that most of our people don't die because of cancer.
Right.
We die because of that bit of management. Because, you know, look at our cancer patients in Kenya. They go for chemotherapy.
Right.
Immediately after that chemo, they're in a public bus.
Yes.
Okay? They are exposed to over 20 people with different types of infections. You don't know what. Even the germs themselves. Okay? Where they are going, their home, their home status, where they're living, there are no hygiene. They're not hygienic.
Yes,
they're not in hygienic
sterile.
situations. In India, and I say this because it should be everywhere, is that my wife used to be isolated. Nobody would see her apart from me. And even immediately after she had got that, I had to sanitize myself. I had to make sure, even my shoes, there were special shoes I was given that I would walk into her room. Now, when you come back home and you see these things are not happening, then you wonder what is all this we're talking about medical? What is medical? People say we are taking patients to India. We are not taking patients to India because we want it. We are taking them because we love them and we want them to live.
Get well.
Number two, let us not say, because, and I don't know whether I'm digressing, let us not say that we are fighting Kenyan doctors that they are not capable. It is not that. Our doctors, there's a belief that whether you go to India or not, you will die. Okay? But, okay, so we say that. But the reason I'm going to die is because my home country has diagnosed me late.
Yes.
When I get to stage 3, stage 4,
India
of course
is
I'm going to
usually
die.
like a Hail Mary. We're just trying
exactly.
to do,
Now,
we are desperate.
and most families, like I told you, the process of diagnosis here, and you'll hear families coming later, much, much later.
Right.
I think we want to go to India now. Because here, we are not, the patient
and they
is
can
not,
see the deterioration.
and they are going when it is too late.
Alice, what was your experience with the treatment? After your team came together and decided?
I actually didn't know the seriousness of chemo.
Okay.
So when they recommended for chemo, the doctor prescribed the drugs at Kenyatta National Hospital. Then I went to the pharmacy. I didn't know how much it would cost me. So when I went to give the pharmacist the prescription, he wrote the prices. So he totaled it up, and it was costing me then 27,000.
How many sessions were you?
That was one session there.
Oh, okay.
But I thought it would take me like 5,000, 3,000. So it really shocked me.
Shocking, yeah.
So I went back to the doctor's room and I told him, oh, okay, I thought this medicine would cost me very little. I can't afford to start today. So I have to go look for money. Then I come back with the drugs. So I went, booked an appointment for the following day. So I went back for the chemo the following day. I did, it was normal, as he says. I took a bus back home.
Yeah, wow.
Yeah, went after about 4-6 hours, then the reaction started coming.
And the reactions are, is it vomiting?
Vomiting, headache, stomachache. You don't feel like eating anything.
Right.
Yeah. So it goes on like for a week. Then it depends on your diet also. Then you start regaining back your...
Were you given information about what you should eat, what to expect? Oh wow! So you're learning by experience.
Yeah, just by experience.
So how many sessions did you have before?
I did 6 sessions.
6 sessions, each 27,000.
Each session now would go after 3 weeks. Yeah.
Yeah. So as we wind up, Dr. Sitna, I would like you to give the audience, the people watching at home, these information that not many people know and just encounter, like Alice, while on treatment? What should they expect with, what type of treatments should they expect, and what do they come with? But sometimes you see people with radiation, with having burns on their body. So what should they expect? Because the effects are usually very negative, but of course, if you have foresight, then maybe it would help in dealing with it, and also the finances.
Okay. So I'd like to address a few things that the caregiver said in terms of treatment. So I think that it's very important to understand that the treatments will be different for different cancers.
Patients.
For different cancers and for different patients. So even if you're looking at lymphomas, they're not all treated the same, hence the reason why you need to actually make the correct diagnosis. And there are some cancers that will need more toxic chemotherapy, like I think his wife received. And in those cases, the risk for infections are higher and the need for isolation is greater. But for example, for all our breast cancer patients, we do not require them to be isolated because they're not getting as toxic as a chemo as what a lymphoma patient is likely to get, and the risk of infection is actually lower. So maybe things have changed since 15 years when Alice was treated, but we are very conscious now of giving patients a lot of information, information booklets, and giving them what the options of treatment. So if you look at a patient with breast cancer, the treatment will often include a surgery, and that may be either to remove the lump or and a section of the breast, that's called breast conserving surgery, or they might require the whole breast to be removed. Having said that, there is reconstruction that's also available locally now. And then they would go on to have chemotherapy based on the findings we get from the specimen in the lab. So not all patients will get chemotherapy, but a majority of them will get chemotherapy. So chemotherapy is not like your antibiotic where you may get a little bit of nausea. So most patients, and now we have even more effective anti-nausea medication. So nausea and vomiting has become less of a problem, but they will have problems with change in appetite, change in how the food tastes. Fatigue might be a problem, and in very few people getting infections might be a problem, but we expect the symptoms to be within the first week, and then after that there's the period of recovery where they go back to normal, and then we do
until
the
next session.
Yes.
All right.
And then there is radiation, which is the application of high dose X-rays to specific areas, and like you said, in very rare cases they will get like a burn on the skin because the X-rays have to pass over the skin to go to the target area. But very, very important to note that not all patients are treated the same, and different treatments will have different side effects.
Right. So I hope we are all well informed on this subject, because it cannot be discussed in one day because there are different forms. But I guess the common denominator is go for testing and get diagnosis early enough so that you can have treatment, and not all lumps come out cancer, right? Yes. So if a lump does not definitely mean that you have cancer. So get yourself tested, and this very often do we find free testing all over, but seek medication early enough, whether or not you're scared or whether or not there is stigma. And that draws us to a close to the show. I'd like to invite Mike.